from 11. Professor Haustermans, the floor is yours.
Thank you, Mrs. Chairman. So the title I got is Improving Outcome, a Case for Neoadjuvant Radiochemotherapy. And as you can see, I put a question mark, which was not in the program. So if you look at radiotherapy for pancreatic cancer, this is how these patients usually present. 15 to 20% are upfront operable, and they should go to surgery and adjuvant chemotherapy. 30 to 40% are locally advanced. They can become potentially operable, and then they can go to surgery, or they are inoperable, and they can go to chemotherapy, just like the metastatic patients. Now you wonder, where is then the role of radiotherapy? Well, here in resectable patients, that's actually my title, we can question the role of preoperative chemoradiation. For sure, in the potentially operable patients, there might be a role of preoperative chemoradiotherapy. In the inoperable patients, we might question the role of definitive chemoradiation. And as was mentioned by the previous speaker, we have to make the difference between locally advanced tumors, which are usually defined as being unresectable because of these reasons, and they should have no clinically detectable metastases. And then we have, on the other hand, the borderline resectable and the resectable tumors. And I will focus on those. Now, before we go into more detail, we have to realize that treating pancreatic cancer with chemoradiation is a real challenge. First of all, we should do individual planning of every patient with a CT and ideally an MR in the treatment position, because MR has much better soft tissue contrast than CT, so it helps the radiation oncologist to delineate the target volume. Treatment position means simply supine position with a knee support. We can question the role of respiratory gating, and I'll come back to that. For sure, we need at least a multiple beam setting. Here you see the tumor, the liver, and the kidneys, because otherwise it's impossible to deliver a high dose to the target without damaging the normal surrounding tissues. We need at least high-energy photons, and we can question the role of protons or carbon in this disease. We should be aware of the normal tissues, because most of the normal tissues surrounding the pancreatic tumors are very radiosensitive, such as the small bowel, the kidneys, the spinal cord, the liver. We look at the dose and the schedule of drugs, and also, of course, at the total dose of radiation, but also the fraction size and the overall treatment time. What are the advantages of giving the chemoradiation upfront, so before the surgery? Well, that we can avoid surgery in patients with rapidly progressive cancer, because we can restage them after the chemoradiation. And if we look at the data, approximately 25% are spared unnecessary surgery because they metastasized in the interval to surgery. If we use upfront chemoradiation, we provide early treatment of micrometastatic disease, and we can potentially improve the R0 resection rate, and especially we can improve it towards the retroperitoneal margin, as was discussed by the surgeon before. Why use pre-op instead of post-op? Well, first of all, you have intact tumor vasculature when you treat pre-op. So we know that radiation is more effective on well-oxygenated cells, and we also get a better penetration of the chemotherapy if the vasculature is still intact. For us radiation oncologists, it's much easier to treat in the pre-op setting because we know where the tumor is, so our volumes to irradiate become smaller, and so we have less toxicity. Usually, the overall treatment time is shorter if you compare it with adjuvant treatment, because patients do not need to recover after the surgery. We can look at response at surgery in the resection specimen, and we know this is a prognostic marker. We have fewer anastomotic leaks, and we have no treatment delay because of poor wound healing. In the borderline resectable, we can obtain downstaging, downsizing, we have a lower risk of positive resection margins, 12% without, 20% with pre-op treatment versus, 12% with pre-op treatment versus 26% without. I already mentioned the improved tolerance of treatment, and if we go through the literature, 1 out of 2 becomes resectable. This is a large meta-analysis with more than 4,000 patients, and here you look at the proportion of resected patients that were initially resectable, and if you compare that with the group that was initially non-resectable, you can see that with pre-op chemoradiation, you can increase the resectability rate, of course not towards the percentage of initial resectable, but still a substantial number of patients become resectable, up to 40%. What you also nicely see in this graph is that there is a relation between the number of patients that are treated versus the resection rate. So volume in the center is important. Now, if we look into the phase 1 and 2 trials that are available on pre-op chemoradiation, first of all, it's usually a mixture between resectable and borderline resectable tumors. So that makes it hard for me to report on results of resectable tumors only. And then you see 2 big ways of using pre-op chemoradiation. Either you go for the full dose of radiation and you combine it with escalating doses of drugs, and then you end up with rather long treatment schedules, 45 to 50.4 Gray. That means 5 to 5.5 weeks of radiotherapy, and you have to be careful about the dose of chemo that you associate with such a long course of chemoradiation. The other way is much more attractive. You start with you use full dose of drugs because a lot of these patients have micrometastatic disease, so you treat the micrometastatic disease early into the treatment process, and then you add escalating doses of radiation, but you limit the total treatment time by using a larger dose per fraction. This is another way of explaining to you why it's for us much easier to treat in the pre-op setting. This is a situation in the post-op setting. You see here the borders of the beam. You can see a huge volume that is irradiated. You see kidneys, you see liver, you see here the vessels. Here is some shielding. This is the lateral view. Again, a huge volume that is irradiated, and this leads, of course, to poor tolerance and morbidity. That is how we do it today. We use at least 3D conformal radiotherapy. Here we can nicely delineate the tumor, and we can limit the irradiated volume around the tumor with optimal sparing of the kidneys and the liver. And this is a comparison of how these beams look. They are a lot smaller than the ones I showed you before. This is a study from MD Anderson, a phase 2, where they looked at pre-op chemoradiation for borderline operable patients, whatever that might mean. Here you see full dose of gemcitabine starting on the Friday before the chemoradiation, 10 fractions of chemoradiation, and then continuously gemcitabine, and then it stopped 4 weeks before the surgery. Here you see that 74% became operable, and of these, 30% of these patients are still alive after 5 years. Here you see overall survival, here you see the resected ones, and of course, the unresected ones have a very poor prognosis. They continued with this approach by combining gemcitabine with cisplatinum. This did not improve the outcome, but we have to be careful. These are consecutive phase 2 trials. But if you look at the results, the gemcitabine compared with the radiation is a little bit superior to the combination with gemcitabine and cisplatinum. And again, resected patients have a better prognosis than patients that cannot be resected. In this study, 66% of the patients could be resected after the pre-op treatment. So if we look at the outcome after pre-op chemoradiation, we have 2 large published series, one from MD Anderson and one from Duke, and you see that the outcome after chemoradiation is clearly better compared to surgery alone. This is how we used to do it: long course of chemoradiation, interval surgery. This is tested in many phase 2 trials: full dose of chemo, short course of radiotherapy, followed by surgery. And this is what we are doing today. We use short course of chemoradiation. We try to add systemic agents in the interval to surgery and after the surgery. This is a big study again. It's the same study as I showed you before. And you see that if you treat resectable patients, and that's 10 to 20% in this study, with pre-op chemoradiation, and you look at the resection rate, it's 74% almost. And in this study, it seems, but we have to be careful because it's a meta-analysis, that if you treat with pre-op chemoradiation, you might have a somewhat superior median survival. Here you see pre-op treatment in the borderline resectable. 33% in this study became resectable, and if they become resectable, their outcome is very similar to the ones that were upfront resectable. So what is the correct answer? The future of radiotherapy for pancreatic cancer lies in adjuvant chemoradiation, question mark. I don't really believe in it, but we have to await the results of RTOG 08. But we have many negative studies, especially from Europe, that looked into the role of adjuvant chemoradiation. Definitive chemoradiation for inoperable cancer, it doesn't seem to be indicated after Lab 07. So neoadjuvant chemoradiation, it is currently the most commonly used indication for chemoradiation. Or are these really the right answers to the questions? Maybe we should better question how we can move the field forward. And here quality assurance plays a major role, but we also have new techniques available, such as stereotactic body radiotherapy and carbon ions. And here you see how small the volumes are that we irradiate when we use stereotactic body radiotherapy. And these are some results in locally inoperable tumors, and it looks that at least with stereotactic body radiotherapy, we can obtain median survival of 8 to 12 months, which is not too bad in this disease. What about breath holds? Here you see the volume in the expiratory phase, axial and coronal, and here in the inspiratory phase. And look, by inspiration, you see an overlap of the irradiated volume with the healthy tissues. So this is again a clear indication that pancreatic tumors move and that we should try to irradiate them in the breath hold position to avoid normal tissue toxicity. Carbon ions, here you see the dose distribution, the depth into the patient, the relative dose. These are the photons we use today. First you have an increase in dose, and then you have a decrease. Here is our tumor. With protons and carbon ions, you have a much lower entrance dose compared to photons, and then they deliver their dose right in the tumor, and there is no exit dose. So by using these new particles, we can avoid much better normal tissue toxicity. And there are several studies from Japan, because there they have carbons, showing that with carbon ions you can get very nice responses in combination with chemo. What about stereotactic body radiotherapy? How does it work? It works very different from conventional radiotherapy. Actually, this is what happens. This is the tumor, one big fraction of radiotherapy, and this is what is left. Why does that work so well? Well, with conventional radiotherapy, we damage the DNA in the tumor cells. But with stereotactic body radiotherapy, we do not only damage the tumor cells, we also damage the cell membrane around the endothelial cells. And this is the result. This is stereotactic body radiotherapy. You have the effect on the tumor, which leads to tumor cell death, but you also have the effect on the endothelium, and that leads to apoptosis and microvascular damage. And of course, that also leads to tumor cell death. If you use a conventional fractionated radiotherapy, you don't see this endothelial damage. And actually, because you don't see this, you can even make your tumor cells more radioresistant to the radiotherapy because you have an upregulation of HIF-1 alpha, VEGF, and FGF. What about the tumor microenvironment? This is in untreated condition. Anti-immunogenic clearly is the major factor in before treatment. If you use stereotactic body radiotherapy, you clearly stimulate the pro-immunogenic response. So this is what happens, single fraction T cells, they release antigens just like the dendritic cells, and this also goes into the circulation. This is an example in animal models where they use radiotherapy in combination with the CTLA-4 antibody and the PD-L1 antibody, and you see what a nice response they obtain in animal models with pancreatic adenocarcinoma. And this is radiotherapy only. This is the combination of the antibodies. You clearly see that with the combination, you have a superior response compared to the single agents. This is a publication from Lancet Oncology, and that is showing another important aspect of this immunomodulation. These are patients with oligometastatic disease. 2 of these metastases were irradiated, and in the 3rd metastasis, we see what we call an abscopal effect. So the metastasis shrunk, the metastasis was not irradiated, shrunk due to the radiotherapy, and that is probably due to this immunomodulation by giving radiotherapy to the primary tumor. But we have to be careful, because this is what happens with ionizing radiation. It is a very delicate balance. Either we go to pro-inflammatory response, and this leads to radiosensitivity, cell death, immunity, and genomic instability. But if we disturb this balance too much, it can also go into the other direction as a kind of feedback loop. And then we see an anti-inflammatory response, radioresistant, survival of the tumor cells, and reprogramming. So when we design future trials in the combination of immune checkpoint inhibitors and radiotherapy, we have to be very aware of this delicate balance. So, to conclude, patients should be accurately staged. Patients should be entered in well-designed randomized trials. Radiotherapy should be planned carefully, both from the physical and biological point of view. More effective systemic agents are needed to maximize radiosensitization and to treat microscopic extrapancreatic metastatic disease. And pre-op chemoradiation offers several advantages over post-op chemoradiation. And this is my final slide. We should always keep in mind that the treatment must not be worse than the disease. Thank you.